So we want to continue to make this emotionally relevant so we don't feel I don't want to be the talking head, although I kind of am based on the technology. But I want us to be able to connect these things together. Uh, and resilience is it's kind of a nebulous concept for primary care physicians because it's hard to put your finger on what it is. But we realize that one thing we know is that the old school one diagnosis, one treatment is really not sufficient to uh, address the impact of trauma on the brain and development. And I'm going to plug a book that's not written here. I should have probably put that reference in, but Relational Health that you see on the slide is a concept that has been recently talked about. Andy Garner from Cleveland is a well-known trauma presenter, and he's a pediatrician. As he always says, I'm just a doc in the trenches. And Andy's book called Thinking Developmentally, it's really a wonderful resource. It has a lot of great vignettes about how we can use the power of the relationship between the pediatrician and the patient and the parents, kind of a three-way triangle that can be a big part of building resiliency. And so it's too expensive of a book, but it's really good. It's really worth the price. And so if you have a hospital account or whatever, grab it. I think you'll enjoy it. So resilience has short, medium, long-term impact on all these entities. This sounds like a commercial. It immunizes, insulates, shields, and protects. It does all those things. It really is like the Star Trek shield build, to prevent trauma impact, mitigate the impact on the brain. That's how we have to think of it. So let's talk about this. So 3 dimensions, the 3D in the title refers to kids, families, including kinship care, foster care, adoptive parents, and biological parents, and also the workforce. So all 3 of these components can will benefit from resilience building. So here's a definition. And Dr. McEwen, who's a stress expert, has some great videos out there. There's one he did for Nat Geo a few years ago that's just called, I think it's just called Stress. It's really good. It's like an hour, but it's really good. It has some great stuff on it. But basically what we're talking about is the factors that contribute to an organism's ability to cope with environmental challenges. It's ensuing its survival. Fancy definition, but it really does kind of tell us what's going on. And what we want to make sure of is that people aren't confused by the strength-based model that's out there, and strength-based folks that kind of promote this get defensive about this. But resilience is more about basically contextualizing the strengths and the adversity, and how do we balance the two, because we really need to do both. And we find ourselves sometimes avoiding talking about the issues that caused the problems in the first place because they happened when the child was young. And we do this. We say things like, didn't that happen to you when you were little? Didn't that happen a long time ago? You're such a good athlete. You're a good singer. You're great at school. You're great on the debate team, and yet if we don't address and put a trauma narrative together for kids that are impacted, they really can't heal. So it's really this balance. And this is a kind of a primitive PowerPoint way of looking at that. Basically, it's really about the two, and how do we and how can we balance that as a team, kind of interacting with other components, other systems that kids are in, like schools and primary care and child welfare, mental health, whatever, all those things, the courts, all those folks have to work together. So bend but don't break is the great way to think about this. And it's summer, we've got these trees out there, and now we can actually go out and be outside a little bit with less guilt and more safe. Um, Deciduous trees are great. They don't do so well when there's high winds, and they're not built for high winds. And what happens is uprooting. Palm trees, designed for high winds. You don't see palm trees uprooting, even with 150 to 175 mile an hour winds. You just don't. They're built to take it. And that's really a great kind of analogy about resilience. So what's it look like across, in the trenches across Michigan? This is a kind of, unfortunately, might be traumatic for some folks, because this is what you've lived with probably your whole career, watching the slow motion car accident that is trauma impact. So we're going to go through this kind of one step at a time, and how we can build resilience as we go. So that we start with prenatal exposure, because that's where we should start. And there have been some really cool programs dealing with pregnant moms when they first get diagnosed with pregnancy, the first office visit. Mom Power is a program that U of M is doing now. Maria Music is a psychiatrist and researcher, is really incredible woman. And she has been implementing this around the state. Now they have a big grant out at U of M's child psych department. And so that's basically trauma therapy on pregnant moms to mitigate impact on the baby. It's quite exhilarating. And why isn't it like universal? How can we implement those kind of things? Then next step is infancy. So now we've got an unresponsive caregiver, often traumatized, as we've talked about, intergenerational trauma. The mom is struggling with all of her issues, often including substance abuse. And that will often end up as an insecure attachment situation. But the other piece of that puzzle is the baby's impacted by all the prenatal things, especially if there's drug exposure, alcohol exposure. So now you've got a baby that's irritable or under-responsive, and you've got a mom that's struggling. And who's going to do anything about that? How come we're not set up to do that? Why don't we have programs as soon as moms get home? They're starting to happen now. But if we wait till the kid turns 3 and they can get special ed workup and home-based treatment, that is not optimal. So we kind of move along a little longer. Now we got a toddler who's being a toddler, who's got issues because they're 2, and the mom is struggling, and the dad or / boyfriend struggling, and all of a sudden that baby's in trouble because he's acting like he's 2. Who steps in and helps this out? How can we do more resilience building in places like daycare? How can we get daycare folks excited that they're part of the treatment team, because they really are. Then we take it to the next step: emotionally dysregulated and aggressive. Okay, whoa, that's already happening. I had a clinic back in the last 5 years of my practice, was all about 3 to 6 year olds, and they were at-risk kids, and we called it was called the early intervention program. And I sat with lots of moms that were bio moms that were struggling, 3 and 4 kids from 3 and 4 dads before, and moms the oldest one is 6 or 7, and I'm seeing the second or third and trying to deal with a whole family of dysregulated kids. How do you do that? How can we do that in a way that is more systemic, and without just being the doctor's going to prescribe a med that's going to magically cure the kid? Then the next step is, now we're starting to see attention issues. Now we're seeing academic struggles because nothing's happened. This whole pathway is the basically if nothing happens. Next, we've got now I got to move this so I can read what I wrote here. Behavior problems at school, suspensions and expulsions. And again, we're already getting into the labels, and it's just kind of it's not a good situation. We go a little farther. Now we've got this very interesting conundrum: the child as bully and the child being bullied, often in the same hour. This is very common. And often the bullying that happens is happening to kids that are at risk and vulnerable. And that often ends up with lots of behavior, willfulness type paradigms that come into play, that, and it's really tough to advocate for a kid who's picking on a kid in a wheelchair, except, you know, we've got to realize that that's a classic kind of trauma presentation. Then we've got the labels starting to fly out. Okay, now they're being seen by CMH. Now they've got an oppositional defiant disorder label, also known as the Antichrist to-do list, and something I like to say. RAD, which is not reactive airway disease, it is reactive attachment disorder. And there's and at CTAC, Jim Henry, we always tease because RAD is bad and makes Jim mad is our slogan. And because RAD kind of implies that the kids are really past the point of being treated, and it's a desperate situation, when we know that attachment is on a continuum, and you can certainly make interventions that matter. And then we start getting early bipolar labels. And like I've said before many times in this venue, severe behaviors do not equal severe or serious mental illness automatically. Then now we've got the kid entering the juvenile justice system. Who's going to build resilience there? Some of my favorite humans are juvenile probation officers that have been amazing folks. They've been part therapist, part horse whisperer, part confidant. And often when they get the trauma piece, they do amazing work at building resilience in their own systems, trying to get the judge educated without stepping over boundaries. And then finally, school failure dropout. Now what? And so we obviously have to intervene way sooner than this. But this is kind of the slow motion car accident that many docs have watched for years and really didn't understand what it was all about. So let's dive a little deeper into resilience now. So these references are excellent. I've got them listed at the end of the slides. So again, if you want the slides, make sure you email me and we'll send them. But Ann Maston's at the University of Minnesota. She's the pediatric resilience guru. Her book's called Ordinary Magic. It's a great name. She has lots of interviews online. She's really good. Southwick and Charney are the adult experts in resilience, and we'll talk about their work with the government when they worked at NIH in the 80s. And that book is thin but powerful. Ginsberg is the family resilience expert. He's a pediatrician from Philadelphia that's written many books. The AAP has published most of them. So here's kind of the framework we're going to use for the rest of the talk. There's two protective factors here with resilience and one at-risk factor. So the first protective factor is relatedness. And we'll talk in detail about this in a second, but I wanted to just give you an outline. We're talking about effective caregiving and parenting. We're talking about relationships with other adults. This is where you come in. The other adult often is pivotal in child's development. And then also, how can we help with helping kids be better friends, and with we call friend maintenance, because oftentimes we've got kids that can make friends, but they can't keep friends. And then this has a kind of direct effect on intimacy and romantic relationships when the child grows up. So that's one. Then the second protective category is mastery or efficacy, and it is based on things like intelligence and problem-solving skills, motivation to succeed, and also competence and self-efficacy. Can I really impact my world with my behavior? So those both categories are very they're essential because they are protective. Then the risk factor that we spend a lot of time on, a lot of money, a lot of resources go to this: self-control, emotional regulation, planfulness. Those things we'll talk about at the end. Things we've already talked about some, but we want to make sure that you realize that this is kind of that yin-yang we talked about earlier. And then spirituality is a little tricky because it's hard to know where to put it in the research model. We know that it matters, but kids with trauma often have confusion about this. We'll often hear, especially older kids that are bright, they'll say, how could there be a God if how could a God force me into a closet and be locked in there for 4 months? How could that happen? That same kid will often say, you know what though, that's, there are times when that's all what really I had to lean on. So how do we kind of put that in that big overarching umbrella? So let's talk about the science of this a bit. The Charney and Southwick book talked about this research that happened after Vietnam, because there was a lot of interest in the wide discrepancy of outcomes for Vietnam soldiers. Why was it 10 years later, in the mid 80s, there were a number of bad outcomes: suicide, homelessness, major psychiatric illness? How come that happened? And then in the same squad, there were guys that ended up being senators and CEOs of companies. What the heck was that? Why was that? And they started researching it based on the science that was available at the time. And so they were able, in a retrospective model, to kind of piece together why the people that survived and thrived why that happened was based on some labs. And they also were able to take it to the next level and predict special forces trainees, which ones were going to have PTSD when they went into the field, based on their lab work that was done when they were doing their training. And can we predict who will be resilient? Things like neuropeptide Y, which is part of the fight or flight system. And the serotonin transporter ends up being a very excellent predictor. And we know now, if you have the short allele of the serotonin transporter, that's the bad gene, from both parents, you have basically a 10-fold risk for PTSD with the same trauma exposure, which is incredible when you think about it. That was discovered in the 80s. We also know a lot more now about the resilience of the genetics and epigenetics and protective genes and vulnerability genes, and how epigenetics turns those on or off, and often in prenatal times. And can we predict this in kids? There's some ethics kind of questions circulating. Will the system eventually decide that kids with excellent resilience by their lab work will not need as much services? And will that end up being happening? And this is what everybody worries about. Oh my God, they're going to take things away because that kid's got high resiliency scores. So telomeres are fascinating. Telomeres are basically a shoelace cap on the chromosome that we'll show you a picture in a second. It's really kind of the nature-nurture kind of balance. And there's an interplay between genetics and life experience, et cetera. And so telomeres really kind of are a marker for aging. And what turns out that here they are right there, the red jabberdoos are shoelace caps. So we know aging shortens those telomeres, leading eventually to a general breakdown of multiple systems. We also know that trauma accelerates that aging, accelerates that by shortening. So trauma by itself shortens telomeres. And we also know from some really interesting research that's been done around the country that social networking in a research model, 2 hours a week with 6 or 8 women in one study that was done with severely handicapped kids and the parents of those kids, that was enough to lengthen the telomeres after 1 year. It was wild. It's like, wait a minute, is that possible? The telomerase discovery was huge. Now, Elizabeth Blackburn discovered telomeres at Yale as a grad student. Her student, I can't think of her name right now off the top of my head, she discovered telomerase in Dr. Blackburn's lab at UCSF in San Francisco. And telomerase turns out to be a lot easier to measure because it's an enzyme assay. Telomere assays are really hard. Only 2 labs are good at it. But this was a big breakthrough. So here's a study that was done by Dr. Eppel, who is one of Dr. Blackburn's colleagues at UCSF. She looked at autistic kids with and their moms and a control group. And she wasn't interested in training the moms to do mindfulness. She wanted to know which moms were already doing it. So they were already practiced. And she wanted to compare their outcomes with moms that were in that kind of, you just tough it out and do it. You don't, I don't do that silly mindfulness. I just do it. And what they found was the moms that used mindfulness on a regular basis had increased telomerase levels during the course of a year, which was striking. And the moms that didn't use it and were literally kind of emotionally distanced on purpose, they had decreases in their telomerase levels that were worse than what was expected over the course of a year. And this was one of the first studies that showed that mindfulness strategies decreases cellular aging. Huge deal. This has been replicated several times, but this is the science you need to think about when you're trying to figure out how to do some of the stuff in your office, that relational health piece that I mentioned earlier. So reasons for hope. Hopefully that will help. So let's keep going. So what can we do specifically to help build resilience using the model we've kind of set up? So we do know this, that what we do to model healthy, resilient strategies is more important than anything we say. This is the old kind of saying, do what I do, not what I say, or do what I say, not what I do. My dad used to say that all the time. It's like, wait a minute. Yeah, and we do it all the time with our kids, but with the modeling is the key. So let's go through each category that we talked about earlier and kind of dive in. So we'll talk about relatedness first, because it's probably the most powerful preventive force. So effective caregiving and parenting, we talked about that. Interestingly, trauma impact on parenting is gigantic. Intergenerational trauma is literally a given. So I know you see this in your offices. And pediatricians sometimes they're at a disadvantage. Family docs kind of have an advantage. They can actually treat the parents as patients. And there were more than one time in my career I wished I could have been the doctor of the parent, although many times I was glad I wasn't, because it was pretty messy. But how do we do that? And how do we tie in substance abuse treatment for that? I really feel like the substance abuse question is so interesting. We're going to talk about this in detail towards the end of this training in the fall. And I've just been going through this with some practices I've been working with up in northern Michigan. But I'm convinced that this addiction as a developmental disorder concept is really underappreciated. Linda Mays at Yale has some great work in this area. And I have a book that's sitting right on my desk. It's called Parenting and Substance Abuse. It's a whole book on this. And Linda Mays is one of the authors. It's been super helpful because there's literally all these developmental points of time that we could intervene to build resilience. And yet nobody's really done all of them in a sequential way. We've kind of done bits and pieces, pilot study here, data here, but not really has there been this interest in going to an organized approach that would start from the very beginning. I'm just hopeful I've still got internet. I don't see anything. Okay, I'm gonna assume I still have it. So dyadic treatment programs are part of this. So how do we set more of those things up where the mom and the baby are treated together right off the bat, right as soon as the kid gets home? They've got programs for like drug addicted babies that have been in NICU with methadone treatment, et cetera. But what about just at-risk families? So how can we do more to help them? And we really feel like that would be a big resilience builder. The next piece of this is relationships with other adults. This is huge. This is where you guys come in. I'll talk about this in a second. And then how do we help kids be better friends? How do we help friend maintenance? And this part is the kind of the likable, charismatic kid is a phenomenon in social work that's always been kind of mysterious. Is how come some kids are just so dang likable? They can do horrible things and you still give them a break. Oh, he's so adorable. I know he set his brother on fire, but he's so adorable. I had a teacher actually say those words to me once, and I went, "Excuse me, what? He set his brother on fire?" Yeah, but he's so adorable. I love him. The gotta love me face. It's like they have 90 lives. It's way past 9. How do we kind of operationalize that piece? So this is what we know. Efforts to cope with experiences of trauma are enhanced when kids have stable, long-lasting connections to stable, nurturing adults. It's just a very well-researched principle. And this is something that's really important. And it's irrationally crazy about the kid. One adult that's just very, very almost irrationally supportive can make a lifelong difference. We hear this all the time from the kids. Real Life Heroes is a program that Richard Kagan from South Carolina put together when he was in Albany at a kind of end of the line residential program that was kind of the last stop before jail. That's what the kids used to call it. And I think the staff used to take bets on which kids were going to end up or how fast they were going to end up in the system. Well, Richard was very brilliant about looking for ways to get connected with these kids because they often weren't talking. They didn't trust anybody, but he would say to them, is there anybody in your life that you kind of sort of trusted? Like there must be 1 or 2 people. It might have been a teacher, it might have been a coach, and it was invariable that within a month or so the kids would say, well, yeah, there was this coach, but I don't think it's going to matter. He only coached me 1 summer. And it turned out that was the only adult in that kid's life that wasn't judgmental. And Richard would do these magical things and find these people on Facebook, and the kids would go bonkers because they realized from the emails that the person really remembered them. And it was a wedge into their treatment. And we really were amazed how many times we hear this in our center, that, who is your hero? And they will often bring up a teacher or a principal or a support person at school or the janitor or the bus driver or the playground supervisor. People you wouldn't expect. Foster care workers often are listed. Therapists are listed. Physicians, believe it or not, are on that list. We hear that. And even the kids will often say, well, I know I get shots there. And yeah. But you know what? That was the only place I could really count on. It was always the same. The outfits were the same. It smelled like a doctor's office. I liked to be in there because it was my safe place. And then foster parents often will get postcards and Christmas cards from former foster kids for 30, 40 years. It's important and underappreciated often. So here's another piece of this puzzle. And the system is really bad at this, especially when kids start going in and out of foster care, in and out of the system. We try to get judges to understand the power of birth families. And what we find is the birth families, they don't get how much damage they're doing. And they'll often say to us when we interview them at CTAC, well, I've always felt I was way better than my mom. I don't hit my kids. I never do that, but I know I yell at them. And they really didn't understand that the yelling and the emotional abuse was very detrimental. And now the research shows that it's probably right up there with sexual abuse as impactful, but they're really not aware of it until you can make them understand it. And so extended families often are left out, and the kids, hasn't told anybody that the only person in the family he really likes is a cousin that lives, in another block over, but nobody mentioned that to anybody. I really see a lot of upheaval in this whole system. And this intergenerational trauma piece is part of the deal. When we were in Colorado doing some work a few years ago, we really found that getting trauma screens on every person in the home was unbelievably helpful. And we're now just starting to develop a trauma assessment model for adults, of the parents of the kids we assess, because we just feel like if we don't do that, we're not going to make this work, because anger management classes for the abusive parent are often the joke, and they'll say things to us like, that anger management stuff doesn't work when I get mad. It's like, what a great line. And it's true. They can't use cognitively based strategies if they're in their primitive brain, and they've kind of triggered into that mode where you can't control yourself. So we really have to try to do better to maintain those connections. And often there's leverage that the judges don't understand. And Frank Vandervoort, who's our trauma consultant at U of M Law School, Frank's got some great lines. He always says to us, hey, the judges don't recommend, they order stuff. So how can we get judges to order intergenerational trauma approaches? Well, they can do that, but if the system's not ready, they're going to get frustrated. But so those are the things we have to kind of get better at. The visitation policies are often a total disaster, because we're asking families at risk to load into a small room and try to have a visitation session, when there's no chance they can do it. And there's been some work with this therapeutic visitation model that's kind of a coaching model that builds on things that we've learned in the parent-child interaction therapy, where the mom or the dad's got an earpiece in, an earbud in, and then the coach who's in another room is actually giving them feedback that's based on a curriculum, so they can positively interact better, learn how to play with their kids better, and get some little whispers like, hey, let him win. Remember, we talked about this. Let him win. He's only 4. You don't have to win every game you're playing with him. So that's all kind of in that relational laboratory model that's all about building connections. So we know from Bruce Perry's work that anything that increases the quality of relationships and the number of quality relationships in the child's life is going to be the best answer. Not always easily done, but we know that it's the way we have to be headed. So this is a great slide about the research about this. In Bruce Perry's second edition of his book, The Boy Who Was Raised as a Dog, it's a great book on Dr. Perry's life as a trauma psychiatrist. Has a whole thing about this. So a responsive adult, and I wrote PCP in there because this is something that we don't think about in our own world in the office. But when you have connections with kids, and sometimes they're really eerie and amazing and scary, when a child that you know fairly well starts talking to you about things that he's never talked to you about, he or she, and you feel like, wow, this is almost bizarre. I can't believe how much he's telling me. I don't know if I can handle it. We call those sacred moments. And we'll talk more about that when we do our secondary trauma work. But those moments, if they're a minute long, they can cause neuroplasticity right there. And this is all based on work from Eric Kandel, who won the Nobel Prize for his memory research with sea snails. I know it sounds weird, but sea snails. And this was in the 80s, basically, when he finished his work, and he started in the 60s and 50s. But he was able to show that synaptogenesis happened very quickly, and he looked at long-term potentiation of memory storage in the snails. But we find that happens when we have those sacred moments. If you have 4 of those moments in an hour, you'll see long-term neuroplastic changes. That's crazy. That's the reason we do this. This is why I want you to take this away from today. How can we keep setting things up so this can happen more often? So that's relatedness. So the next category is self-efficacy, mastery. So what can we do about that? So we know that the keystone of development and resilience are the internal beliefs about the self that are formed early in childhood. And when kids experience success in a consistent way. Not that they're going to get everything they want, but if you work hard, it will pay off in the long run. That will basically wire the brain. Okay. So it basically teaches them they can achieve goals, and they can take risks and fail because they're going to have reliable adults helping them through it. They can overcome anything. It's basically that kind of teaching kids to be perseverant and keep on going. But to do that, they've got to have this kind of support network. And this is very clear. And this is what we talk about all the time in child abuse work. But this support network gives them these opportunities to be successful. This relational security is really what this is. That says, no matter whether you're successful or not, you're valuable and lovable. This is not unconditional love as long as you're good. And we sometimes run into that in foster families, in bio families. It's like you can't be graded on a curve that way. You know, the love part can't be withheld as a behavioral tool. Because when it doesn't occur, kids start looking at success or failure as this all or nothing for the parents' love. There was a case I was involved with up in northern Michigan a couple of years ago. It's very, very awful. But the mom was very mentally ill and she had Munchausen's issues. But she somehow in her mind set up the three kids she had. There were 4, 5, and 7. Their job was to duke it out in a room, and she would hug the one that was standing at the end. That's literally how she did it. And we couldn't prove it until the cops came in and did a CSI trace for blood, and they finally found some evidence and were able to get the kids, get her out of the house. But the kids start doubting their value if they're not successful, and they start believing the labels. And we've had kids tell us, you know, we've asked them, how often do you get told you're bad? And when this 10-year-old we saw, he said, I don't know, 1,000 times. After a while, it's easier to believe that. It's like, whoa, that's big. Because shame is the piece of that. That shame is, you know, guilt is, I feel bad because I did something wrong. Shame is, I am a bad person. And that's what happens in the trauma world. And kids that are maltreated always believe it's their fault. And they'll say things that are mind-boggling. I was bad, now my mom is dead. Or worse, I killed my mom. I was mean to my sister, now I can't see her. If I was nicer, my dad wouldn't be in jail. Irrational thought processes, sometimes from 5-year-old kids, but that's how they're making sense of things. They're trying to make meaning in their mind, and that's how it fits, even though it's not accurate. So they're bad, and no matter what they do, good things are not going to happen. That's an awful place to be, but that's really the impact of trauma. And the victim mindset is, I don't deserve the success. If it does happen, it won't last. And this locus of control thing, meaning everybody's doing stuff to me. There's nothing harder when professionals and, you know, out kind of onlookers start hearing that blame, the kind of shift of the blame. It gets hard to be supportive and advocate for kids. They expect to fail. They lose motivation. And then they have this thing called learned helplessness, which is not good. And then its cousin is pervasive powerlessness. Whoa, that's when you really kind of just go, you know, F it, nothing matters. Why am I doing this? So what can you do about all this? This is a heavy stuff. What are the antidotes to this? Docs have a lot of power in just the relationships and the words that we say to patients. And how many times have you heard researchers say, yep, the data says if the doctor personally talks to the patient about smoke cessation, that the success rate goes up 25%. How come that is? How many times have you heard this? Some people are mad, like family members. I've told him that 45 times and you say it once and he's listening to you. Well, that's because what we say does resonate. Empowering kids, preventing victimization, making sure they hear from you this way, and it's got to be genuine. Discovering and supporting their hidden talents. We tell teachers all the time, when you've got an opportunity, maybe the kid's drawing instead of working, but how about turning that drawing, because there's some talent there, how about kind of processing that and sharing that with the class and trying to use that to engage the kid in other work. And then if there are moments when they're basically showing their skill set, how do we trumpet that out? How does the doctor take time to mention that? That's something that you can set up in between visits, so they remember that, and write a note to yourself so you bring it up the next time they come in. This is something that unfortunately gets cut when there's money issues: sports, music, and art, or gym class, and we really focus on trying to avoid using skills as a negative reinforcer. As one of the program directors I used to work with would say to the new arrivals at his program, find out what they're good at so we can take it away. That was like this cryptic mode that I used to just really hate, because it seemed like it was just so counterproductive. But we do it often without knowing it. Okay, so down the stretch we go. So we've talked, those first two categories were protective, right? So let's talk a bit about the affect regulation piece. Now, realize that we're going to do a whole presentation on these things, so I'm not going to spend a ton of time with them, but we're going to come back to this a little bit later. But the priority is, the earlier we do this, the better. And the behaviors, we've talked about this, the behaviors that we see in the foster care system that are deal breakers, especially when the placement's threatened, that's when we'll see that the medication gets overdone as a way of kind of survival. And there's a willfulness paradigm. The willfulness paradigm kind of sneaks in here often, that they were making bad choices when it was really a brain issue. So this is back to that brakes accelerator model we just went through with the medication that we did last month and the month before. That balance between the brakes and the accelerator. Remember, the brakes is the prefrontal cortex. The accelerator is more about the limbic system and the brainstem. And how do we keep kids in that Goldilocks comfort zone, the just right energy level, and no matter what it takes. That's really, we know that if kids, the more the kids are in that level, that Goldilocks level, the more chance they're going to be to wire their brain in that place. So what can you do about that? So and again, we're going to spend a lot of time talking about this, but sensory focused OT and strategies. How do we get that out to the masses? How can we do more of that in the school setting? How can we do some of that in the home setting? How can we use music and movement? Music therapy is amazing. We're going to have some info on that. Music group experiences that don't require a music therapist, which is that website there, musictogether.com, is a great model that they've got a training program for schools now that you can do online. There's a lot of, this came about because there's just not enough music therapists, especially in rural areas. Equine therapy, we're going to talk more about that in one of our future episodes. Equine is amazing. I've been working with the Peace Ranch in Traverse City for the last 3 years, and very impressed with Jackie Cashel, the director there. They just did a thing on her on Channel 9 up in Traverse City. So there's an article if you want to Google it. And EGALA is the best evidence-based model. It's a kind of three-person treatment team, with the third person being the horse, but it's a horse specialist, a therapist, and the horse. And the model there is, the humans are trying to stay out of the way and letting the horse do its thing with the child. And the horses that Jackie has are all rescue horses that all have trauma backgrounds. And horses are prey animals anyway, so they're very tuned in to regulation and noticing things. They're very good at breaking through with kids that struggle because you don't need language to connect. And they're also big, so kids that are aggressive don't have any luck being aggressive with the horse. And it's really quite amazing. If you've got an EGALA site near you, check it out. And then we talked last time about medication, how medication, when it's done in a brain-based way, can contribute to that regulatory treatment. So trust-based relational intervention, we did a whole session on that. You heard about how much that can help the kind of regulation is one part of their model. Conscious Discipline is a website that talks about getting the adult to stay regulated and how that helps the child. And then all sorts of stress reduction strategies that are all part of this affect regulation model. Things like Mind Up from the Goldie Hawn Foundation, which is a K-8 curriculum-based program that they've serviced 3 million kids since 2003, and it came after 9/11 basically. And they've got a training program that will actually come to the school that you want or the agency. It's really not that expensive, and it's really impressive. And they do a lot of teaching about the brain. Zones of Regulation is another program that basically it's a mix of sensory strategies and social communication interventions. So it's a cool combo, and it's rapidly gaining momentum. And we're going to use it in a grant project that we're hoping to get funded up in the UP. Yoga, trauma sensitive yoga has been an evidence-based model for a while. It started in Boston, and we used yoga in one of our school programs that was really way more successful than any of us thought, because the kids there were mostly guys. There was only 3 women in the program. This is middle school and high school kids. And they saw eventually that when they were doing yoga, they literally couldn't get mad. And they would start doing yoga during class because the other kids would give them the prompt. And this was all something we were working on in our group sessions with them. It was really quite interesting. And we started seeing that some of the kids were teaching the yoga stuff to their parents and step-parents and boyfriends and girlfriends of their parents. Quite cool. The other program that we have used, and it's from Yale, it's called Activate. And it is a combination of yoga, Tai Chi, and aerobics, plus computerized executive function training. And it's a model done at the school. And we did it with about 53 kids at the center-based school we were working with. And there's a minimum of 1,000 minutes of training that you need on the computer to make the evidence base happen. So 1,000 minutes, 1,500 minutes is actually the ideal. And this is a kind of a school year driven model. So the kids that got 1,000 minutes accumulated in our program, every one of the kids that did that had at least a 50% improvement in executive function based on the model, which is an NIH cognitive toolbox assessment model. It was crazy, including one kid who was not excited about this and did not want to do it. And our approach to that was, you can either do it or you can watch other people do it. So that was what and this kid was Mr. Negative the entire year. And when we told him at the end of the year that his brain had improved 50%, he said, what a classic line, "I did not give you permission to change my brain." It was funny. And then one of his friends said, "Hey, dude, I changed your brain when I taught you how to roll a joint." That was like, okay, that was special. But yet he goes, fine motor skills. You couldn't do that before. That changed your brain. It was quite interesting. But that website's worth looking at. So those are some kind of an example of what you can do. The therapy world has regulatory built into it. Infant Mental Health has 2 really exciting programs. One's called PCIT. I mentioned it already. It was designed for inner city teenage moms back in the day, not that long ago, 15 years ago or so, and teaching teenage moms how to play with their kids. And the before and after videos on the presentations I've seen are just wild. And again, it's a scripted model, and there's an earpiece involved, so that the therapist can give prompts to the mom while she's playing with a kid in another room with, you have to have a remote setup. It's pretty cool. CPP is kind of a little younger population. It's really one of the few infant programs, and it was developed by Alicia Lieberman at University of California, San Francisco. Alicia's a friend of CTAC and an amazing woman. And she actually was trained by Selma Freiberg, who is kind of the mother of infant mental health. She was at U of M. She was basically a school social worker in Wayne County. And it was one of the few people that was a faculty member at U of M in their psych department. But she and Selma retired, went out to California, trained Alicia, and then unfortunately passed away from a brain tumor. But CPP is a long training, but now the state or U of M has got a contract now with some of the CMHs in terms of, it's a grant funded program to get this going. And it's kind of, it goes with the mom power thing I mentioned before, that prenatal trauma therapy. And then the handoff is from mom power to CPP, where there's therapy sessions that are basically mom and baby combined. It's a really cool program. TheraPlay, some of you have heard of. It's getting more popular. Their evidence-based is better. Their research is stronger now. They use this on a wide age group. There's a residential program in Illinois, at Quincy, Illinois, called Chaddock, that actually the entire program is TheraPlay based, even though they don't tell the 18-year-olds there that they're doing play therapy, but they are. Target is a program that we used at one of the schools that I mentioned before. And we had, and Target is a group model that is more about psycho-ed, and we're not asking the kids in the model to talk about their own experience, but we're trying to teach them how to recognize when they're losing it. And what was interesting about the Target model is the same thing would happen. The kids were totally clueless about their triggers and how they looked and if they could see it coming. They could not recognize it in themselves, but they could do it in other kids. And it was like every other kid would understand the kid we were working with, their triggers, but they couldn't see it, but they could understand everybody else's. So it was really quite amazing to watch the transformation when everybody started getting everybody else's triggers. It was really powerful. And then TFCBT is the kind of 600-pound gorilla of trauma therapy now. It's pretty much the preferred method in Michigan with the system kids. It basically involves psycho-ed and stress reduction strategies, and then finally constructing the trauma narrative, where you kind of put all the pieces together to kind of understand what you've been through. Trails is a group psych program that comes out of U of M that's now kind of popping up into different schools in the state. And Sparks is not seen very much in Michigan. It's a really cool program that's it's group trauma therapy that was developed in South Carolina. A little tricky to implement, but their numbers are quite powerful. And then we're going to spend a whole session on secondary trauma. And that's going to be down the road a bit. Because that's really how you get a resilient workforce together, is you have to have a way of being aware and recognizing and treating secondary traumatic stress. And you got to have leadership connected, and you got to have trauma training. All those things have to go in, and more programming and services. So, all right, and the books we talked about, these are those books. And again, if you want the slides, just email me, I'll send them to you. They're all excellent. And this is a website with more information on resilience. And that's it. So, yay, we finished. So thanks for hanging in, and see you next month. I'll send you I'm going to update the schedule, I think, because I don't think we're going to need to do any more on resilience. But I will let you know what the new schedule is going to look like. And thanks for supporting us and hanging in there. Stay safe and be well.